Here we'll start our discussion about pharmacology with pharmacokinetics. I think we'll talk about pharmacodynamics of each drug or drug class as we discuss those in different videos. But here we'll go over pharmacokinetics, which is what your body does to a drug. So what happens when you give an IV drug? This is a little bit different than when you give oral medication in terms of where the drug goes and what will happen to your plasma concentration over time. So imagine you give an IV drug. It'll go through the veins up to the patient's heart, and then from the heart, it will be sent to the brain. It will be sent to the liver, kidneys, etc. And so this drug is being sent all over the body at different rates, essentially. So we want to know, especially for the brain, for our anesthetic medication, how much is going there? How can we predict how much drug is actually reaching the brain, and then how fast as well? Because that will tell us essentially what the onset of our anesthetic medication will be. For anesthetics, the brain is the effect site. So the concentration at the effect site is what we are concerned with. That's the effect site concentration. And the brain is the effect site of our IV medication. So this will be very sort of similar to the plasma concentration. I hesitated there because the effect site concentration will be lower than the plasma concentration. But for lipophilic drugs, these will approach the same number quite quickly. So we'll probably be talking about the plasma concentration of drugs for the remainder of the video. Just remember that for lipophilic drugs, the effect site concentration in the brain will approach the plasma concentration relatively rapidly and be quite similar. So again, where is the drug going when we give it by IV? We have this group of organs called the vessel-rich group, and that is the brain, which is good, the heart, liver, and kidneys, as well as the adrenals. So this group of organs receives a lot of blood flow. It receives 75% of your cardiac output, despite only being about 10% of your total body weight. So these organs will receive a large fraction of blood compared to their tissue concentration, and therefore more drug will initially be delivered to these organs when given IV. Other is muscle, which is about 20% of your cardiac output, and by comparison, 50% of your total body weight. Fat has even less, so about 6% of your cardiac output, and maybe about 20% of your total body weight. Then you have your vessel poor, which are things like bone, ligament, and relative to all these other things, it's basically 0% of your cardiac output, but 20% of your total body weight. These do get some blood flow, but it's almost inconsequential compared to the amount of blood that goes to these other organs. So certainly blood flow is one of the things that affects drug delivery to the tissues, and hopefully this idea of the vessel-rich group has already made that clear, but let's draw that really quickly too. So let's pretend that we have a group of tissue here that it's vessel-rich. There are many vessels running through this, versus over here we'll just have one vessel. And let's pretend that this is supplying the same volume of tissue. Just to drawn vertically here and horizontally here. So we have drug in the blood vessel being taken to this tissue. And it will diffuse into the tissue. Here, the same concentration of drug is being brought to the tissue, but since it has less blood supply, less of the drug is delivered to this tissue. So in this volume of tissue here, we got 2 of these drug molecules. Here we got 6. So having more blood flow increased the amount of drug in this tissue. The solubility will also increase the drug concentration in your tissue. So imagine again you have a vessel and your drug needs to cross into a tissue, and if it is soluble in this tissue, it will more readily transfer into that tissue. So for example, the blood-brain barrier requires that a drug be lipophilic to diffuse into the brain. There are actually transmembrane channels that will transport hydrophilic drugs, but this occurs much more slowly. So for drugs to reach a decent effect site concentration at the brain, they do need to be quite lipophilic. And then plasma binding of the drug also has a big impact on how much of that drug will actually be delivered to the tissue. So let's say that these are albumin proteins, and then we have a drug that is highly bound to the albumin. There will still be free drug floating around, but only the concentration of the free drug is able to equilibrate with the tissue. So over here you have your tissue. So let's say your free drug over here is 5 micrograms per mil. The most concentration you'll ever see on this side, again, is 5 micrograms per mil when it equilibrates, if it ever does. Even though there is quite a bit more actual drug on this side, maybe if this albumin wasn't there, you'd have a concentration of 25 micrograms per mil because of how much physical drug molecules are on this side. But only the ones that are free can equilibrate with the tissue. So imagine if you were expecting a drug to bind to albumin, but you have really low plasma albumin levels, then you'll have a much higher concentration of this drug in your blood, and much more of it will go over to your tissue. So now we've established that when you give an IV drug, it will go to various tissues in your body and be carried to them by a different amount of blood flow that these organs receive. The solubility of the tissue matters, and some combination of these things will determine what the concentration of that drug in any given tissue is. So let's look at what happens when you give a Propofol bolus. This is Propofol. So on the y-axis, we'll have the plasma concentration in mics per mil. And on the x-axis, we have time. So about here, we'll say that's 5, and this is 1.5. So we give a decent bolus. So let's say we give about 150 milligram bolus to a person. We're going to see that pretty much right off the bat, you'll be able to measure some plasma propofol, and we'll have a peak of this, and quickly after that, we will have our plasma concentrations fall. Okay, let's say our therapeutic range for propofol is in here. Therapeutic range. And here we'll just define what we're looking for as unconsciousness. So this is therapeutic range for unconsciousness. You could define a different therapeutic range of propofol being one that maybe causes amnesia, and that will be much lower. You could say that we want our therapeutic range to be a depth of anesthesia sufficient to prevent a response to laryngoscopy, and that therapeutic range might be much higher. But for unconsciousness, in general, we know that as long as your plasma concentration and thereby your effect site concentration in the brain is about above 1.5 mics per mil, you will have unconsciousness. And then anything above 5 mics per mil is really just unnecessary. So we can see here that by about 8 minutes in after your bolus, our plasma concentration has decreased to the point where it will no longer keep you unconscious. So why does the plasma concentration decrease? And I'll tell you, it is not from metabolism. So this is not the half-life of the drug. This is not that. The reason your plasma concentration decreases when you give an IV medication, you have this rapid drop-off, is because the drug has distributed itself to other tissues. So it's no longer hanging out in the plasma, it is now maybe in your muscle and starting to go into your fat. So let's show you that here with the drug distribution of propofol. So we'll make the y-axis here 60, this is going to be percent of your propofol bolus. So 60%, 30%, and then time down here. So 30 minutes, and let's make this logarithmic, so 300 minutes over here. So your blood concentration will be about like this, and it will decrease and approach zero. Your vessel-rich group, so the drug that is distributed to your vessel-rich organs, will be very close to what that plasma concentration is, because it's in pretty tight equilibrium with that due to the fact that it receives so much blood flow. So it will follow pretty much that same curve. So this is your vessel-rich group, and this was your blood. Your muscle, which does not initially receive as much of the drug, will slowly increase in the amount of propofol that it has, and then decrease again. Fat starts low and will creep up. And lastly, I'll show you what happens to the actual drug metabolism. It's very, very, very low. Okay, and then by 300 minutes, your drug is then being metabolized, or a substantial amount of the drug has been metabolized. So you look at 30 minutes into giving propofol, you are way less than 30% of the drug that's been metabolized. So obviously, when you're at 8 minutes into your bolus, this decrease in your plasma concentration has nothing to do with the drug metabolism. It instead has to do with the drug going to other tissues. So your muscle is now hiding some of that drug, and some of the drug is hidden in your fat as well. So it's this concept of distribution of the drug that is very important for when or how long we see the effects of that drug.